Today we'll be discussing about endocrinology. So we'll be discussing mainly about the endocrine emergencies, what we'll be saying. Okay, that's the important part of endocrinology. We'll not be discussing all the endocrinology, which is not important from exam point of view or from your workplace point of view. First, let's discuss about diabetic ketoacidosis. As the name suggests, diabetes. Diabetes means either he is a known case of diabetes or there is an increased level of glucose. Ketones. Here there will be increased levels of ketones. Ketones are nothing but acid. So there will be decrease in pH or nothing but metabolic acidosis will be there. Why does this happen here? Because of an insult. There will be an insult because of an infection, or it might be because of an infarction, like myocardial infarction, like ischemic stroke, or it might be because of any illness this patient is having. It might be because of an sepsis, or it might be because of an burns, something like that. Or the patient has not taken sufficient insulin. He is a known case of diabetes on insulin, but he has not taken sufficient dose, or he has forgotten to take the insulin. So any one of these insult is present, there will be increased levels of cortisol, a stress hormone. The cortisol levels will go up. These cortisol levels will hamper the utilization of the glucose what is there in your bloodstream. That's why the glucose will remain in your bloodstream. The body will think there is not enough of glucose because the body is not utilizing. That's why it will break down the fatty acid to form ketones. These ketones are nothing but acid, eventually will result in metabolic acidosis. So what is the criteria to diagnose DKA? As the name suggests, this patient should be known case of diabetes, or the blood sugar should be more than 11 millimoles per liter. Acidosis should be present. Either the pH should be less than 7.3 or the bicarb should be less than 15. Mainly we'll be looking for the pH. Other thing, the ketones are on the higher side. The ketonemia, especially the beta hydroxybutyrate, we will be looking for, it should be more than 3 millimoles per liter. These are the blood ketones what we are looking for. Okay. Or there is a significant ketones in the urine, that is more than 2 plus on urine dipstick when you are doing, which is more sensitive. Blood ketones are more sensitive compared to the urine ketone. So the all three criteria needs to be satisfied for an adult patient to be called as an diabetic acidosis, or to label him as an diabetic acidosis. There should be increased ketone levels, that is more than 3 millimoles in the blood, and blood sugar levels should be high, that is more than 11 millimoles per liter, or he should be a known diabetic, and there should be an acidosis. That acidosis, the pH should be less than 7.3. So what are the clinical features? As sugar levels are high, this patient will have polyuria, polydipsia, increased urination, and increased thirst. There will be loss of lot of fluid in the urine. This is mainly because of osmotic diuresis. Because of osmotic diuresis, there is lot of fluid, results in hypotension and reflex tachycardia. What happens GI tract? In GI tract, there is abdominal pain, nausea, and vomiting. It is not exactly known why it is. There are various theories behind it. One of the theories is it might be because of decreased or hampered gastric mobility. Because there is because of diabetic ketoacidosis, there will be metabolic acidosis. Because of metabolic acidosis, the respiration will be rapid, so that there is washout of carbon dioxide. The respiratory compensation is happening. This breathing is known as Kussmaul's breathing. And if you go close to his mouth, you can see smell and fruity smell. That is nothing but an acetone breath what you're smelling. What about neurology? There might be an altered sensorium or reduced level of consciousness in these patients. What are the investigations we are getting it done? One set of investigations is for the diagnosis. Another set of investigations to see the underlying cause, that is the insult what we talked about. Okay, for diagnosis, we need blood ketones or urine ketones and blood gas. Venous blood gas is sufficient. We shouldn't get an arterial blood gas because taking blood sample from an artery is a painful procedure. You just need an pH. So venous blood gas gives a good pH that should be sufficient. Along with this, you need blood sugar levels. So all these three are required for the diagnosis purpose. Next thing are to look out for underlying cause. Is it a myocardial infarction which is predisposing it? Is it an infection which is predisposing it, or is it something else like electrolyte? Electrolytes are also important here because of the complications which might occur due to diabetic ketoacidosis, like hyperkalemia. Hypokalemia can happen. That's why you need to get electrolytes also along with urea and creatinine. Because of dehydration, this patient can go in acute kidney injury. That's the reason we are getting creatinine and urea. Along with this, get electrolytes. Coming to the treatment per se, we will discuss about the treatment along with the pediatric DKA so that you can easily correlate and remember them. Just remember, if the adult patient is on long-acting insulin, you can continue taking, or he can continue taking the long-acting insulin at the usual dose and the time as he was taking. What are the complications we can see? If you do an overcorrection, there might be hypoglycemia. Because of metabolic acidosis, usually these patients will have pseudo hyperkalemia. Sometimes if you overcorrected or you are undercorrected, or once you start insulin without correcting the potassium, it can go low also. So hypokalemia can also happen. Cerebral edema, pulmonary edema, and aspiration pneumonia is mainly because of low GCS. Cerebral edema and pulmonary edema usually occurs if you do a rapid correction. Both complications are not commonly seen in adults, especially the cerebral edema is commonly seen in child. So it becomes very important to calculate the fluid what you are giving and how much insulin to be given in pediatric age group. So we'll be discussing about this in coming up slides. So we are entering into the pediatric diabetic ketoacidosis. Remember that I have not discussed the management here. I'll be discussing along with the pediatric. So let's discuss about pediatric diabetic ketoacidosis. What's the difference from the adult? The definition itself, there is a little bit of difference. Here, we are taking only two things. One is acidosis, another one is ketones. Both are similar to that of the adults. There is nothing special. Both are similar to that of the adults, so we can remember exactly the same. So there is no difference. The only thing which is difference is there is no mention of he should be a known case of diabetes, or the bedside glucose what you're checking should be more than 11 millimoles per liter. It's not there in the pediatric criteria. If they satisfy acidosis, if they satisfy ketone criteria, you can label them as diabetic ketoacidosis. Let's see how they are classified. Adult, they don't usually classify as mild, moderate, and severe. But in pediatric, they classify as mild decay, moderate decay, and severe decay, depending on the pH. If the pH is between 7.2 and 7.29, we call it as a mild. If it is between 7.1 and 7.19, we call it as moderate. If it is between, or sorry, it is less than 7.1, we call it as severe. If it is severe, there are few changes in the treatment. That's why it becomes important you remember the pH. Less than 7.1 is severe. You need to remember this because the treatment changes. For mild and moderate, it remains the same. How treatment changes, I'll let you know in coming up slides. What about the investigations? Investigations are similar to that of adult. Nothing special here, similar to that of adult as we discussed previously. So you need not relearn it. Just apply the knowledge what you have of the adult is the same investigations. Now we are coming to the management of diabetic ketoacidosis. What is the management of diabetic ketoacidosis? Slightly complicated management. We need to start them on insulin, but mainstay always remains is fluids in both adults and pediatrics. Because of high glucose levels, they would have lost a lot of fluids through the urine, resulting in severe dehydration. So we need to restate this patient if required. So let's see the treatment of DKA. First, we'll talk about adult, followed by we'll be talking about pediatric. If the patient who presents to the emergency department is in shock, that means systolic blood pressure is less than 90 millimoles of mercury, then we'll give boluses. So now we'll be giving either 500 or 1000 ml of normal saline boluses over 10 to 15 minutes. If required, we'll keep repeating till the blood pressure improves or the patient is going into fluid overload. Fluid overload is highly unlikely because there is an osmotic diuresis. What is happening here? They will be dehydrated, so we can give enough fluid to pick up the blood pressure. What if they are not in shock? If they are not in shock, What Endocrinology Society recommends is giving 1 liter of normal saline over 1 hour. Next 1 liter is given over next 2 hours. Next 1 liter is given over next 2 hours. Okay. So 1 liter over 1 hour you are giving it. What about insulin infusion? We start insulin infusion at a rate of 0.1 units per kg per hour. For example, 70 kgs will be starting at 7 units per hour infusion. Okay. Usually this infusion is started after giving 1 liter of saline or 1 liter of fluid, then we'll be starting it. So you started the insulin infusion, you have after 1 hour, you have checked it, but still the ketone levels are not falling down. We are expecting the ketone levels to fall by around 0.5 millimoles per liter per hour. If this target is not achieved, you can increase the infusion rate by 1 unit. For example, in this case, it is not reducing by 0.5 millimoles per liter, then we can increase it to 8 units per hour in this patient. What about potassium correction? Get the potassium values. Don't start the correction without having the potassium values. Once you have the potassium values, usually will be available on the blood gas. Look at the potassium levels. If they are really high, you already started insulin, usually need not do anything unless they are having severe hyperkalemia, then hyperkalemia treatment might have to be started. Or else if they are more than 5.5, don't intervene. When they are in the normal range, add 40 millimoles to 1 liter. That means this 2 liters fluid, what you are giving, just add 40 millimoles. This 1 liter, what you're giving over 2 hours, just add 40 millimoles of potassium in that and give it over 2 hours. What if it is less than 3.5? Then you're adding around 60 to 80 millimoles per liter you are adding. You're just adding to this resuscitation fluid or the fluid what you're giving, you're adding the potassium to that fluid. What about if the glucose levels falls very rapidly low, but the ketones are not falling, ketones are still high? It's a very well documented phenomena which happens most of the scenarios. At that point of time, you will start 10% dextrose at 125 ml per hour and continue the insulin infusion. How do you monitor these patients? Get ketones and glucose hourly, pH and bicarb, that is basically venous blood gas, you are getting it hourly for the first 2 hours. So first hour and second hour, you'll get it done. After that, every 2 hours once you can get it done. Electrolytes at initial presentation, then after 4 hours, you are getting it done. What about management of a pediatric? It's slightly, or if not completely different from the adults. Here, we are mainly worried about cerebral edema. You can't just rush the fluid. We can't just start the insulin infusion in these patients because these patients can have cerebral edema very fast. Okay, that's a known complications, very life-threatening complications. We don't want to harm the patients. So everything is calculated in pediatrics. If the patient presents with a shock in pediatric age group, we will give 10 ml per kg fluid boluses and we will repeat as required. So this fluid bolus is given over 15 minutes. If required, we'll keep repeating it. If there is no shock, what we'll be doing? Every patient who is not in shock also will get a fluid bolus of 10 ml per kg given over 30 minutes. Then we'll be calculating the requirement. Then we'll be starting the fluid at that requirement. So what is this requirement? This requirement, what you need to remember here is you need to calculate the deficit. Then you need to calculate the maintenance. Maintenance is given over 24 hours. Deficit is given over 48 hours. Okay. Then you need to subtract from this is the 10 ml bolus, slow bolus, what you're given in non-shock patients. You need to subtract. But in a shock patient, if you're given boluses, you need not subtract at all. No matter how many boluses you are given in a patient who is in shock, you shouldn't subtract it. Insulin infusion is started at a rate of 0.05, half that of the adults you are starting. Okay, you're giving after 1 to 2 hours of IV fluids. In adults, we give it after 1 hour. Here we wait approximately 2 hours to start the IV fluids. Not immediately, after 2 hours of IV fluid to start the insulin infusion. Okay, insulin infusion is not immediately started. We wait at least for hours, if not 2 hours before we start the insulin infusion. Here is the change which you need to remember in severe decay, that is the pH less than 7.5, as we studied in the definition. We call it, if the pH is less than 7.5, we call it as in severe decay. In this patient, you will start the insulin infusion at a higher rate, that is 0.1 units per kg per hour, after giving fluids for at least an hour's time. What about potassium correction? If it is above the upper limit, add 40 millimoles to this maintenance requirement what you are giving. If it is in the normal range, you are adding 40 millimoles per liter to this fluid what is happening here. Okay, but the difference in this both is, as I said, both are quite similar, but when the potassium levels are high, don't start immediately. You wait till the patient passes urine. Once he passes the urine, then you can start the potassium correction. Otherwise, don't start the potassium correction immediately. Here, you will start the potassium correction immediately once you add it in the fluids what has been going on. What if it is less than 3? In less than 3, again 40 millimoles. Along with this, insulin should not be given till it is more than 3 millimoles per liter. Potassium should be more than 3 millimoles per liter before you start the insulin. So in everything you can remember, it's 40 millimoles, 40 millimoles. If it is in normal range, you are not doing anything. If it is above the normal range, you need to wait till the patient passes urine. If it is less than 3 millimoles, then you need to wait till the lab report shows that, or till the potassium correction is done and it is more than 3 millimoles per liter. What if the glucose levels falls down? That is, if it falls below 14 millimoles per liter, what we'll do at this point of time? At this point of time, change the fluid to 5%. We're changing it. We're not starting a new insulin. We're not starting an infusion of 5% glucose. Instead of that, we're not starting a separate one. We're starting, or we are replacing this normal saline what we told here above. The maintenance or the requirement itself, we are changing it to 5% glucose. We're not starting a separate infusion here. If you have started the insulin infusion at 0.1 units per kg per hour, reduce it to half, that is 0.05 units per kg per hour. Reduce it by half. Ketones, how do you monitor? Ketones and capillary glucose should be checked every hourly, as mentioned previously. Urea, electrolytes, bicarbonate, pH, and laboratory glucose. First, you need to get it done after first at the presentation, after 2 hours, then every 4 hourly you can get it done. The last bit what we are talking about is how to calculate the deficit. How to calculate deficit? First, you need to know fluid deficit. Fluid deficit, if it's 7.1 to 7.29, that means if it's mild to moderate decay, then you have to take it as 5. If it is severe decay, then you have to take it as 10. Then multiply with kg weight into 10 will give the deficit. This has to be given over 48 hours. So per hour will be whatever it is there, divided by 48, you will get per hour how much you need to infuse. What about maintenance dose? Maintenance dose is 100 ml per kg for the first 10 kgs. For example, if it's 21 kgs, first 10 kgs, it will be 1 liter. Next 10 kgs, it will be 0.5 liters. Then every kg here will be 20 ml per kg. So it will be 0.2. So you'll be giving 1.7 liters over 24 hours. So again, 1700 divided by 24 will give in ml how much you need to give it. The fluid calculation is quite complicated. Unlikely they will ask you to calculate in the examination, but they can ask you the formulas. What is the formula of deficit? What is the formula? How do you calculate and maintenance fluid? Just they can say. What is the requirement? Requirement is deficit given over 48 hours, maintenance given over 24 hours, and you have to minus the slow infusion or slow bolus what you are given. So every patient who doesn't have a shock will get a slow bolus. So it's a quite complicated management of pediatrics, so that that's the reason we have put it up in a tabular form so that you understand better. There is an example here how to calculate, or it talks more about the fluid deficit here. So requirement is deficit plus maintenance. Deficit is calculated over 48 hours. So we know the formulas. We know we need to assume it is a 5% deficit if it's mild or moderate. We need to assume it is a 10% deficit if it's a severe DKA in pediatric age group. Maintenance fluid, as described previously, 100 ml per kg. You need to give it for first 10 kgs. Next is 50 ml per kg. Next is 20 ml per kg. This will be discussing again in dehydration in pediatric chapter. There is another formula what you can use it which calculates directly per hour. We'll be discussing in pediatric chapter once again this one. Okay. So here it gives an approximate calculation, slightly complicated calculations what they have been doing. Unlikely they'll ask you in exam. Previously they used to ask because they used to have a lot of time for a single question. Here you have approximately 1.2 minutes in exam to answer the question. It's impossible to calculate. They might just ask you what is the maintenance fluid, just use this formula, or they might just ask you what is deficit and use the deficit formula as described here. Use this deficit formula, it is much simpler. Use this deficit formula, it is much simpler. So next thing is complications are quite similar to that of adults, but we need to separately discuss about cerebral edema. It is very important in pediatric age group. Before we go through it, there are a few more things you need to remember in the management. If it is an adult or a child, do not, or you should stop the pump. Okay, for example, few patients will be on a continuous insulin pump that will be implanted subcutaneously in them, especially in the patients who are type 1 diabetes who should be on insulin. For them, there will be an pump which is already been implanted in them. Okay, there will be switch. So ask the patient, they will be knowing how to operate it. Stop it. Don't start your insulin infusion along with this pump. Okay, and along with this insulin therapy. If you do it, the patient will have recurrent episodes of hypoglycemia. The child or an adult who is already on long-acting insulin, they can continue. Never give any sodium bicarbonate in patients who are acidotic. Especially in DKA patients, bicarbonate is not advised at all. You just start the insulin infusion and give them the fluids, the pH will come back to the normal. Don't give bicarbonates. Now let's talk about complication, that is cerebral edema. What are the signs and symptoms here, what you're seeing? These patients can have headache or irritability, or can show slow heart rate, that is low heart rate plus high blood pressure, indicative of Cushing's syndrome. Okay, reduced GCS because of increased ICP, and other signs of ICP also can be seen. Mainly signs of ICP what you see during cerebral edema. If the patient develops any sign of cerebral edema during DKA treatment, then whatever fluid you are giving, you need to cut down by 50%. At the same point of time, with a neurosurgeon's advice or neurologist's advice, you might have to give a 3% saline or start them on mannitol to reduce the cerebral edema what this patient is having. This is also important. Okay, the whole DKA what we have discussed is very important. If anyone has any questions regarding pediatric or adult DKA, you can ask me now.
So can you just explain me the potassium correction in pediatric DKA once again?
See, the pediatric correction, whatever you are doing is you are adding 40 millimoles per liter to the fluid what you're giving here. So the requirement fluid what is here, for the same requirement fluid, you're giving 40 millimoles, you're adding 40 millimoles per liter. But there's some clause involved. When it is above the normal range, don't add it till the patient has passed urine. When it is below normal range, don't start the insulin infusion till the potassium levels are more than 3 millimoles per liter. Okay, that will be the potassium management in pediatric age group.
But why, if it is above normal level, why we are adding 40 millimoles per liter, say?
Once they start passing urine, then we are starting. Why we start here, especially here, and again, if they're in normal range also, why we are giving? In this patients, why we give it is usually because this hyperkalemia, what is there, it's because of the exchange of hydrogen ions. Hydrogen ions are Because of acidosis, hydrogen ions are pushed inside the cells and exchange of potassium. That's why the potassium goes high in decay. It is not true hyperkalemia. It is a pseudo hyperkalemia. It's a false hypokalemia, what we call it. But it's not an false because of wrong laboratory ratings. It's because this potassium has come out from intracellular space. Once you start the correction, this hydrogen ions will start coming out, the potassium will start being pushed out once you start the insulin. That's why we start giving this. Potassium levels will start falling very rapidly, especially in pediatric age group. That's why if it is high also, we just wait till the patient passes urine, then we start them with 40 millimoles per liter potassium correction.
Sure, sir. Thank you.
Doctor,
Yes, please.
about sodium bicarb, you said don't give sodium bicarb. This is include pediatric and adult, or only pediatric we are not give sodium bicarb?
In pediatric, there is absolute contraindication to give it because it will cause cerebral edema. In adult, you can take a clinical decision. If it's severe decay, for example, the pH is 6.8 and the patient is in peri-arrest, then you might have to give it.
Okay, that means only pediatric will not give.
Yes. This end changes what you have done, more specific to the pediatrics, but it overlaps with adult also. For example, long-acting insulin, you will continue both in pediatric and adult. Here also, you stop the insulin pump in both adult and pediatric. Soda bicarb, it's more specific for the children and young adults, or around the teenage group from 12 to 16 years of age group. Young people means. Let's go with euglycemic decay. As the name suggests,
sorry, sir, about sodium bicarbonate. Even bicarb less than 5 and pH 6.8 or 6.9, I will not start by sodium bicarb.
Usually in pediatric age group, soda bicarb is not advised.
Okay.
It will correct on its own as you start the treatment. Okay, so you need not rapidly correct it. If you correct the pH rapidly, there will be cerebral edema, it will cause more harm. So if you see, if a pediatric kid who is having low GCS and having a severe decay, it takes a longer time for them to come back. It takes at least 12 hours or at least a day to come back to normal GCS. Same thing in adults. Usually, if once you start the correction, once you get enough fluids and start the insulin infusion, their GCS improves very rapidly. So the treatment is quite aggressive in adults compared to the pediatric because they do it mainly because of cerebral edema, which they're really worried about. Now let's discuss about euglycemic decay. This is a variant of decay where the sugar levels are normal. This is mainly because these patients are non-diabetic and they keep checking their glucose levels at home. Okay, once the glucose levels are high, they start treating themselves and start giving insulin. So they do a partial treatment of decay. They start giving subcutaneous insulin. They do a partial correction. So the glucose might have fallen down, but the ketones will remain high. Then we call it as an euglycemic decay, where he's a non-diabetic, but the glucose levels are within the normal range. What we do or how do we treat this patient? Quite similar to that of the decay. Just what you need to remember is as the glucose levels are within the normal range or it is less than 14 millimoles, then we'll be directly starting on 10% dextrose at 25 ml per hour. We'll directly start the infusion along with all other treatment. Okay. Insulin, same, no changes of insulin rate, what we are talking about. If glucose falling despite of starting at 10% dextrose, then you will reduce the insulin infusion, what is going on to avoid hypoglycemia. Another thing what you need to remember is there is a new class of drug, not very new, it's been used in last decade, is known as SGLT inhibitors. These inhibitors are quite known to cause or very prone for euglycemic decay. Exact reason is not known, but they are very prone to cause euglycemic decay. How does this class of anti-diabetic medications works? They increase the excretion of glucose in the urine. That's how they'll bring down the intravascular glucose levels. As they are excreting more glucose in the urine, these patients are prone for urinary tract infections. Once they are on sodium glucose co-transporter inhibitors, they are prone for urinary tract infection. So whenever the GP starts them, they tell them, whenever if you start having urinary tract infection symptoms, come back to us, we'll change the diabetic medications and start you on the treatment. There is more GP, you need not remember. Hyperosmolar hyperglycemic state, HHS is the short form. What happens here? This patient never develops an ketones or never develops an acidosis because of increased ketone levels. What happens? Because of high glucose levels, the glucose levels will be more than 30 millimoles per liter. Really high levels of glucose are there. Because of these high levels of glucose, the serum osmolarity will increase. It will be more than 320 milliosmoles per kg. Usually it should be in this normal range, but here it will be more than 320 milliosmoles per kg. Okay, so what is the criteria here? There will be marked increase in glucose levels and osmolarity will be really high. Because of high osmolarity, this patient will be severely dehydrated because of osmotic diuresis. Okay, and along with this criteria, there should be absence of significant ketones, as discussed with the DKA definition. Significant ketones, for example, in blood, if it is 1 millimole, 2 millimole is fine. If it is more than that, then we might have to think about DKA. So ketones will not be significantly high. How do we treat these patients? Fluid and electrolyte management is similar to that of the DKA. So you need not learn anything separately, similar to DKA. What do we monitor? We mainly monitor glucose and osmolality here. Okay, if the glucose or the osmolality is not falling down, then we might have to start the insulin infusion. The mainstay of treatment of HHS is fluid. We don't start insulin in this patient until and unless the glucose levels are not falling down by 5 millimoles per liter per hour, in spite of giving adequate amount of fluid. Then you might have to start the insulin at and half of the dose what we start in a DKA patient. The other criteria is if beta hydroxybutyrate, one of the ketone bodies, if this is more than 1 millimole per liter, then also you need to start on insulin at a half dose what is prescribed in DKA, that is 0.05 units per kg per hour you will be starting. As these patients are severely dehydrated, there will be concentration of the intravascular fluid that will predispose to thromboembolism. So prophylactic low molecular weight to prevent thromboembolism needs to be done in these patients. Hypoglycemia. Now we are all talked about high glucose levels. Now we are talking about low glucose levels, which is hypoglycemia. What are the causes? Most common cause is if they take insulin or oral hypoglycemic drug and didn't have enough food, enough calories they didn't have, or they exercise more than what they're supposed to do or more than what they usually do. That results in hypoglycemia. This is the most commonest cause. There are other causes also which you can remember as explain as mnemonic, exogenous drugs. For example, a beta blocker poisoning or an alcohol ingestion can cause hypoglycemia. Pituitary insufficiency, liver failure, especially when there is an hepatocellular carcinoma, which leads to HCC leading to liver failure, will result in hypoglycemia. Addison's disease, notorious to cause multiple episodes of hypoglycemia. Tumor, which secretes insulin, or non-pancreatic tumors which secretes insulin. All this you can remember it with a mnemonic as explained, which causes hypoglycemia. Remember, if you're not able to remember this also, it's fine. This is very important. Next thing, Addison's disease is the important. Two things at least you need to remember from exam point of view. What are the symptoms? There are two main classification of symptoms what this patient presents with. One is because of increased sympathetic tone, there will be sweating, palpitations, shaking. They might not complain of hunger at all in some patients, or there might be some amount of hunger, okay, some amount of nausea this patient is having, okay, hunger, weakness. Neurological symptoms, mainly the neurological symptoms are like irritability, confusion, speech difficulties, is very upset, very nervous, don't know what is happening, severe headaches can happen. Neurological symptoms usually doesn't appear still the glucose levels are less than 2.5. That's when hypoglycemic seizures or severe headaches, reduced GCS levels are all seen if the glucose levels falls less than 2.5. More than 2.5, unlikely they have neurological symptoms. Mainly at that time, the predominant symptoms will be because of increased sympathetic tone, that is autonomic symptoms will be there, like sweating, palpitation, shaking, hunger, and nausea. What are the investigations you need to get it done? Get any glucose levels done. Liver function tests are important because if this patient is non-alcoholic or if the patient is in liver failure, can cause hypoglycemic episodes. Urine creatinine also becomes important in this patient. They can go in because of severe dehydration and other symptoms, they can go in acute kidney injury. Serum potassium levels and ECG is important. ECG to see any potassium correction changes are there. Here we mainly expect this patient to have low potassiums. What is the management? Management mainly depends if the patient's GCS is normal or if the patient GCS is low. If it is normal, you do oral correction. So orally what you can do, first you give a fast acting carbohydrate, anything like a chocolate you can give, or you can give and commercially available gels like glucogel, where you just keep it in the mucous membrane of the tongue, just below the tongue or under the tongue you can place it, followed by long acting carbohydrates like an biscuit or a toast can be given. If the patient is having low GCS, then you need to give intravascular correction. 10% glucose is given, 50 ml bolus. Okay, we're not giving like 25% glucose or 50% glucose because it is quite painful infusion from a peripheral line. At the same time, it can cause thrombophlebitis, that is inflammation of the vein. That's why we give 10% glucose, 50 ml bolus. Then if required, you can give repeated bolus. Usually check the glucose level after 10 minutes. You need to check random blood sugar levels. If they're still low, you can repeat this boluses till the glucose levels are high or within the normal range. Glucagon, if you're not able to get an IV line, then glucagon can be given IM. Remember that it is not effective against sulfonylureas drug induced or sulfonylureas drug overdose. Yes, come and you're trying to bring the glucose levels up. Don't give glucagon, it will not be effective. Liver failure also, glucagon is not effective. It's especially helpful if the patient is aggressive or having seizures. Just give an IM shot, then you can get an IV line. Okay, because someone who is actively seizing, getting an IV line becomes very difficult. Admit all the patients who are on sulfonylureas drugs or long-acting insulin. Why? The chances of recurrent hypoglycemia are there if the patient is on sulfonylureas or long-acting insulin because they act for longer duration. Long-acting insulin like gargline acts for 12 hours. Sulfonylureas acts for 24 hours. So anyone who is taking sulfonylureas or overdose of sulfonylureas, keep them for at least for 24 hours and start them on infusion. Especially sulfonylureas overdose, they're prone in presence of CKD, that is any kidney injury, plus sulfonylureas overdose. These patients are prone for recurrent hypoglycemia in spite of having an infusion of 10% dextrose. In those patients, octreotide will be helpful. Okay, this needs to be remembered. Most of them are not aware of this. That's the reason I'm putting across here. When to check the glucose? Every 15 minutes, 10 to 15 minutes, they say. Usually in pediatric age group, 10 minutes. Adults, you can wait till 15 minutes to check. What about hypoglycemia in pediatric age group? In pediatric age group, the capillary, the bedside, the prick, what you do is not that accurate whenever it is less than 3 millimoles. That's why preferred method, if the patient is asymptomatic, then send a laboratory investigation to check for hypoglycemia. We usually correct the hypoglycemia if it is less than 2.6. Normally in every adult and pediatric, we call it an hypoglycemia if it's less than 4. Here it is less than 2.6, where we consider for treatment. Recheck after 10 minutes. Treatment remains kind of very much similar, where if the GCS is normal, in less than infants, we usually like to give milk feeds. If mom is not breastfeeding or milk feed is not available, you can give fast-acting carbohydrates like glucogel. If it's more than 1 year, fast-acting carbohydrate directly is preferred over milk feeds. What about low GCS? In low GCS, again, same options here, but you need to remember the dose. 2 ml per kg is the starting dose of intravenous 10% glucose. You can give a maximum of 5 ml per kg as in bolus in a single setting. Glucagon is 1 mg if the weight is more than 25 kgs. It's 0.5 mg, that is half the dose of adult will be giving if the weight of the kid is less than 25 kgs. Doses are important here. You need to remember the doses. Newly diagnosed diabetic ketoacidosis, it's more of in pediatric, but again, there is a patient who comes off and he has a diabetic symptoms and the random blood sugar is more than 11 millimoles per liter. You can label him as a diabetic patient and refer them to GP. If they don't have any complications, usually we don't treat. No matter what the sugar levels are, we don't treat them. We just refer them to the GP so that they can start them on regular medication. It's quite similar to that of the hypertension, what we discussed in cardiology chapter. Anyone has questions till now can ask me before we go into adrenal gland.
Assalamu alaikum, Karamir.
Yes, please.
In DKA, you said in pediatric, you start insulin after 1 to 2 hours from the starting IV fluid. In adult, when you start insulin
We
immediately,
usually wait for hours time. Approximately hours time we can wait.
Need to check potassium to see hypokalemic or.
See, if it is hypokalemic, we'll start the correction with the fluid, what is going on. Along with the potassium correction, you can start an insulin infusion. In adults, it's not very clearly described that whether you need to start immediately insulin infusion or you can wait. Ideally, we wait for some time and start the insulin infusion. If the options are like glucose plus insulin infusion, if the options are like IV fluids plus insulin infusion is there in adult, you can choose it. Okay, there's no harm in giving insulin at the start itself, at the presentation itself. In pediatric, we wait because insulin infusion, if you directly start in first 2 hours itself, chances of cerebral edema are high.
Doctor, hypoglycemia in pediatric, same adult 4 or 3?
Sorry, same as?
Pediatric hypoglycemia, same
Okay.
the adult, because the adult hypoglycemia from 4.
Yes, it's remains the same.
Pediatric.
It's 4 itself for both adult and pediatric. But we start treatment in pediatric if it's less than 2.6. Usually they remain asymptomatic till 2.6 in pediatric. In adults, usually autonomic system like increased sympathetic tone symptoms like palpitation, sweating, hunger will start appearing if the glucose levels come less than 4 itself.
Okay, thank you.
Let's go ahead with adrenal gland. Okay, just a little bit of anatomy before we enter into the emergencies. There are 3 layers. The outermost layer is glomerulosa. The middle layer is fasciculator. The deep layer is known as reticularis. You can remember it as GFR. G secretes mainly, the outermost layer secretes mineralocorticoids. Middle layer is glucocorticoids. The innermost layer secretes androgen. Let's discuss about adrenal crisis. We're not talking about adrenocortical insufficiency. We're talking about crisis. Okay. In crisis, what happens? There is an insult. Similar to DKA, there is an insult here also. It might be because of an infection, trauma, infraction, an acute exaggeration of asthma, hypothermia, alcohol, any one of these conditions. Basically, there is a stress. Whenever your body is under stress, there should be increased levels of cortisol to cope it up. Because there is already an underlying insufficiency, this patient will undergo an adrenal crisis. The most commonest cause here, what happens is the patient is taking steroids. For example, for acute exaggeration of steroids, he's taking a steroids, for example, 40 milligrams of prednisone is taking since 1 month, and suddenly he stops or suddenly forgets to take it. That is the most commonest cause to trigger an adrenal crisis. How do they present? They present with a profound shock. They'll be tachycardic, hypotensive, and there will be no urine output at all. There will be profound shock. And whatever, in spite of giving IV fluids, in spite of starting inotropes, the blood pressure will not increase. Then you need to really think about whether this patient is having an adrenal crisis. But there are other clues which will help you to pick up much faster than doing trial and error by giving IV fluids and inotropes. They classically present with 3 things which go low and 3 things which go high. Things which go low are sodium, blood pressure, and glucose levels. Things which go high are potassium, calcium, and there will be hyperpigmentation, that is increased melanin secretion will be there, that will result in hyperpigmentation. So these are the classical features what they present with. May not, all of them may not be present. Important thing what you need to remember is sodium levels will be low, potassium levels will be high. This is very important to remember. Along with it, this is one of the causes for metabolic acidosis with normal anionic gap. As we have studied from our previous chapter, that there are only few handful of causes for metabolic acidosis with normal anionic gap, like loss, like in diarrhea it can happen, or small bowel fistulas or pancreatic fistulas it can happen. Another cause is adrenal crisis, where you can see normal anionic gap with metabolic acidosis. So how do you manage a patient where you're suspecting an adrenal crisis? There are two protocols which are followed in the UK. This is from the Endocrinology Society, European Society of Endocrinology. What they advise is either you give 100 mg hydrocortisone stat, followed by what you'll be doing is 200 mg, you will be starting infusion over 24 hours. This is one criteria. The another criteria is you're giving 50 mg of, again, hydrocortisone every 6 hourly you are giving it. So you are giving a stat dose of 50 mg, then after 6 hours, 50 mg, after 12 hours, again 50 mg. So you're giving 4 times in 24 hours you need to give, or QID is the dose here. These are the two things what you need to really worry about. If the patient is in hypotension or dehydration, still in spite of giving steroids, then you can do a fluid resuscitation. But the mainstay in emergency department is giving steroids. Preferred steroid is hydrocortisone, preferred over methylprednisone or dexamethasone. Any other steroids is hydrocortisone. So remember hydrocortisone, remember this much, that should be sufficient. The two protocols you need to remember from exam point of view. So exactly opposite of what we saw in adrenal crisis. Adrenal crisis is nothing but Addison's disease. Opposite of it is Conn's syndrome. It's also known as primary hyperaldosteronism, also known as most common cause, or most of the time it's because of bilateral idiopathic adrenal hyperplasia. The opposite findings are seen here. There you are seeing hypotension, here there is hypertension, uncontrolled hypertension. There potassium levels are high, here potassium levels are low. Sodium levels, there it is low, it is high here. So exactly opposite picture what you're seeing. If you're seeing an opposite picture, then you need to think about Conn's syndrome here. Okay. Similarly, an renal artery stenosis also can present, but underlying renal failure, that is high creatinine levels, will be there. That will help you to differentiate from an Conn's syndrome from an renal artery stenosis. How do we manage? We just symptomatically manage these patients. We can't give any specific, there's no specific drugs. For example, significant hypokalemia, you might have to transfuse. Hypernatremia, you might have to give half saline, or you might have to give a lot of fluids in this patient. Uncontrolled hypertension, then you might have to start them on drugs like labetalol and control the blood pressure. Labetalol is quite preferred here compared to other drugs. So it's mainly symptomatic treatment. So treatment, they'll not ask you. If at all, if they ask you, they'll ask you the diagnosis. This is a low yield one compared to the adrenal crisis. Adrenal crisis is a very high yield one. Multiple questions can appear on that. What is pheochromocytoma? Pheochromocytoma is nothing but it is a tumor which is secreting lot of mineralocorticoids. Because of that, there will be increased in blood pressure. At the same time, this patient will have headaches. Headaches are classically described as episodic. So just remember, as hypertension plus episodic headaches, all other symptoms are quite non-specific. Anyone who presents with hypertension with episodic headaches, during this headache, if you check the blood pressure, it will be quite high. Then suddenly, without any treatment, it comes down. Then you need to suspect of pheochromocytoma. Whenever you're suspecting an endocrine tumor, always get the particular hormone levels. If they are high, then only scan. Otherwise, don't scan these patients. Many a times there might be an adenoma, but there will not cause any increased hormone secretion at all. So most sensitive test for pheochromocytoma is plasma metanephrine levels. You get a CT scan done later on to see what's the size of the tumor, if it's bilateral adrenal glands which are involved or not, you need to get a CT scan done, imaging needs to be done. What is the treatment in ED? In ED is mainly control the hypertension. How do you control the hypertension? Hypertension, the preferred drug or drug of choice here is phenoxybenzamide. If it is not given, then you can choose pentolamine. Phenoxybenzamide is preferred because it's a non-competitor antagonist. Competitive antagonists like pentolamine can also be used. Both are alpha blockers. Alpha blocking should be done before beta blocking. Don't give in this patient labetalol. If you give labetalol, what will happen? It will just block beta receptors. It will not block alpha receptors. If alpha receptors are not blocked, there will be unopposed action on the alpha receptors, causing severe vasoconstriction. Severe vasoconstriction invariably will increase the blood pressure. So it will cause more harm if you give a drug like an labetalol in this case, which causes beta blocking. Any questions still here? You can ask me before we go into Nelson's syndrome.
So, Ramin, in Cone syndrome, how can treat the hypernatremia with hypokalemia?
Hypernatremia, most of the time we treat it just by giving an fluid, that's normal saline. If the patient is euvolemic or he is in fluid overload, then we can give half normal saline. Then again, if only symptomatic, we treat hypernatremia, otherwise we don't treat. Sodium levels we don't treat until they are symptomatic. So mainstay where there also it will remain as managing the blood pressure, bringing down the uncontrolled blood pressure what the patient is having.
Dr. Amin, in pheochromocytoma, if we mistakenly started with beta blocker, should we give glucagon and give alpha blocker, or how can we deal with this situation?
Stop the beta blocker what you're giving and suddenly immediately you need to start on the alpha blocker. Once alpha blocking starts, then you can add a beta blocker also. So you need not give glucagon to reverse it. Just give an alpha blocker, the BP will drastically fall down.
Sir, in adrenal crisis, sir, should we give first beta blocker or direct?
Steroid. Steroid is the mainstay treatment for adrenal crisis. Why do you want to give a beta blocker in adrenal crisis? There is reduced secretions of cortisols. So you don't want to give any beta blocker. The blood pressure will fall down. First of all, they present with low blood pressure. If you give a beta blocker, the blood pressure will rapidly fall down.
Okay.
Doctor, adrenal crisis can appear in pediatric?
Can happen. Okay, it's not only restricted to adults. In pediatric also, for example, asthma is very common in pediatric age group, and suddenly parents stop giving him steroids. He's on oral steroids and suddenly they stop, he can present with adrenal crisis at that time.
What about pheochromocytoma?
Mainly seen in pediatric age groups. Pheochromocytoma is diagnosed in pediatric age group. Coming to Nelson's syndrome, okay. This may not, again, it is a low ill. So what is low ill? I'll let you know. It is a low ill topic. It may not appear, but you can easily remember what is Nelson's syndrome. What happens here is there will be past history of Cushing's syndrome for which he has undergone in surgery and removed bilateral adrenal glands. So it will be at least 10 to 15 years back this would have been done. Over a longer time, over in decades time, there is a negative feedback which is going because pituitary hormone is always secreting ACTH, and this hormone is unable to secrete more often cortisol at all. Adrenal gland is not there at all. So because of continuous stimulation of pituitary gland, because of negative feedback, the pituitary adenoma can happen. Once there is a pituitary adenoma, there is increased secretions of hormones. All the pituitary hormones, there will be increased secretions, especially ACTH and melatonin stimulating hormone. As pituitary adenoma happens, this adenoma increases in size, it compresses on the optic tract. Compression of the optic tract, which is right below the pituitary gland, will cause bitemporal hemianopsia. Increased secretion of melatonin secreting hormone will cause hyperpigmentation. And there are other hormones in the pituitary will result in high prolactin levels. For example, if it happens in males, they can present with gynecomastia. In females, who are not pregnant themselves, they can present with lacrimation. Hyperthyroidism is very important. They can ask you questions from here. Let's superficially just touch about the causes. Most common cause is Graves' disease, where antibodies are secreted against the TSH receptors which are present over the thyroid gland, results in diffuse, this is important to remember, diffuse enlargement of the thyroid gland and increased secretions. One more thing, as it is an autoimmune disorder, there might be other autoimmune disorders like type 1 diabetes mellitus, pernicious anemia associated with it. Second most commonest cause is toxic multinodular goiter. Okay. Other things like Hashimoto's thyroiditis, initially it causes hyperthyroidism, later on it causes hypothyroidism. Iodine-induced hypothyroidism also. Aminoterone, most commonly used antiarrhythmic drugs also can cause hyperthyroidism. Subcutaneous thyroiditis and suppurative thyroiditis also can cause. Malignancy like single nodule is present that is called as toxic adenoma can cause. This much you need to remember. But remember that most commonest cause is Graves' disease followed by multinodular goiter. It is an idiopathic. We don't know exactly why there is a multinodular goiter. It's an idiopathic cause, what we call it. We are not worried about hyperthyroidism or hypothyroidism. How does a patient with hyperthyroidism will present? He will have increased appetite, but there will be weight loss. Increased appetite, in spite of having a lot amount of calories, this patient is having a weight loss. Okay, there will be increased sweating this patient is having. There might be tremors this patient is having. So basically, we're talking about increased sympathetic activities in this patient. Increased metabolism is happening. Thyroid hormone is required for metabolism. So increased metabolism is happening. That's the reason you are having sweating, tremors, weight loss, and increased appetite. It's like you are always running around. So increased metabolism is there. What about hypothyroidism? Hypothyroidism, exactly opposite of this, they will be presenting with. What we are worried about, diagnosing in hyper or hypothyroidism from a stem of question is easy, but we are worried about thyroid storm. That is an emergency which you need to act immediately. So what are the general causes? Again, like an infection or a trauma or an preeclampsia can stimulate, or acute myocardial infarction or a DKA, HHS. So any acute medical disorder can trigger a thyroid storm. Thyroid specific causes like high doses of iodine, abrupt discontinuation of antithyroid medications, or overdose of thyroid hormones, or direct injury to a thyroid gland because of an infarction, or direct trauma, someone has punched to your neck, can result in thyroid storm. There is a scoring which classifies it into high, impending storm, or unlikely, not required from exam point of view, not required from your clinical point of view also to remember. Coming to management, what is the mainstay of management in thyroid storm? Beta blockers is the mainstay. We'll go according to airway, breathing, circulation, and if required, you'll be intubating the patient. We do it for any patient who comes to research. But what is the mainstay of specific treatment for thyroid storm? It's beta blockers, especially propranolol. Why propranolol is preferred beta blocker compared to other beta blockers like labetalol, esmolol? Why propranolol is preferred over them? Propranolol has an additional action. It prevents the conversion of T4 to T3. T3 is the active form of thyroid hormone. So it prevents the conversion of T4 to T3. Along with it, the peripheral effects of thyroid hormone, it gets into control. So propranolol is preferred over other beta blockers. The other beta blockers like esmolol you can give, metoprolol you can give, or in calcium channel blocker also you can give to bring down the peripheral symptoms. Like verapamil you can give it. Doses are not important to remember. Remember that propranolol you can give it orally also. It is as effective as giving an IV. You can give it orally also, or you can give it IV also, whichever is required. If low GCS, give it IV. If GCS is normal, the symptoms are not that drastic, then you can give it orally. Followed by, we usually give an hydrocort 200 mg IV. We can give it dexamethasone also. This both inhibits the peripheral effects of thyroid hormone. How to inhibit the synthesis of thyroid hormone and release? By giving antithyroid hormone like propylthiouracil or carbimazole. Propyl thiouracil acutely is preferred because it again prevents the conversion of T4 to T3, which is the active form. Iodine also prevents the also inhibits the synthesis of thyroid hormone. First, you need to give propyl thiouracil, then only iodine needs to be given. Treat the underlying insult. What is there? If there is a myocardial infarction, it's a DKA, HHS, treat that. Remember that don't give this patient aspirin, because aspirin should be avoided because it displaces thyroxine from thyroid binding globulin and increases the serum free thyroxine levels and worsens the symptoms. Myxedema coma is exactly opposite to that of the thyroid storm. This patient usually presents with low GCS, that is altered sensorium, hypothermia, reduced temperature, or the temperature will be normal range where you're suspecting this patient to have a high-grade fever. There is a severe infection, but this patient is having an normal temperature, or there is very low-grade fever, or the temperature is in the normal range. Usually, most of the time, the temperature will be low, or it will be normal, or slightly on the higher side, like 37.8, 37.9. There will be a precipitating event. Similar to that of the thyroid storm, there will be a precipitating event. How do we treat? Mainstay of ED management here in myxedema coma is again giving steroids. Thyroid hormone replacement should be started here. Okay, so you can start, but they don't suggest to rapidly give. Usually they start around 40 mcg, then they slowly increase it as requirement. More of an acute medicine management here. From emergency point of view, we are treating underlying cause and giving them a dose of steroid. Pituitary apoplexy. The whole pituitary gland is destroyed or it is damaged. How or why? Because of an acute hemorrhage or because of an infarction. How this a hemorrhage or an infarction has happened in the pituitary gland? It might be because of a head injury, because of the anticoagulants what they're taking, or it might be because of an radiotherapy or endocrine stimulation test you are done which has gone wrong, or it might be because of Sjogren's syndrome. Sjogren's syndrome is a nice one, which one you need to remember. In pregnancy, a pregnant lady or who is having pregnancy, the pituitary gland usually enlarges in size. Why it enlarges in size? Because there is increased demand for this hormone because of the presence of fetus. Soon after delivery, increased size in size because of increase in demand, and there will be, or this will be increased demand for blood supply also. Okay, why increased demand for blood supply here happens? Because it's a larger gland, requires more blood so that it can synthesize more hormones. Soon after delivery, if this patient ends up having an postpartum hemorrhage, PPH, postpartum hemorrhage, primary or secondary, the blood supply will come down drastically down. If the blood supply drastically comes down, the enlarged pituitary gland will not get sufficient insulin, will not get sufficient amount of blood, will result in infarction. That is known as Sjogren's syndrome. Let me just repeat. Pregnant lady, pituitary gland enlarges because of increased demand. Enlarged pituitary gland needs more blood supply. So after delivery, if the patient has a postpartum hemorrhage, the blood supply will drastically reduce to the pituitary gland, which will result in infarction. This is known as Sjogren's syndrome. So as the pituitary gland is hemorrhage or there's infarction, there will be severe headache, nausea, vomiting, photophobia can happen, decreased levels of consciousness might be there, along with the signs of meningism can present and bitemporal hemianopsia can present. Okay, these are all because of the injury to the pituitary gland. Get all hormones which are secreted with the pituitary gland and get an MRI scan. Pituitary gland cannot be visualized with a CT scan itself. Okay, that's the reason you need to get an MRI scan done. Again, the treatment, you can just give a steroid and do a supportive management and involve the neurosurgeons here to intervene if required, if it's an hemorrhage. Otherwise, nothing much can be done from emergency point of view. The mainstay of treatment here is giving steroids, supportive management involving neurosurgeons. Before getting an MRI scan done, get this hormone levels done. If they are low, then only go ahead with an MRI scan done. Don't get an CT scan done, mainly because CT scan doesn't pick up pituitary gland. You can't see pituitary gland on an CT scan. Next thing we are coming is diabetic insipidus. There are two conditions. The counterpart or exactly reverse of it is inappropriate syndrome of inappropriate ADH secretion. Here, the ADH levels are really high. Here, the ADH levels are really low. The ADH levels are low because of cranial. Okay, there is not much secretion of ADH at all, or the ADH is getting secreted normally, but it is not acting on the kidney at all. Then we call it as a nephrogenic diabetes insipidus. If there is a decreased secretion of ADH itself, then it should be something wrong in the brain at the pituitary gland level. So it might be because of head injury or meningitis or pituitary tumor or any vascular injuries. Nephrogenic is important because most of the time it is either because of low potassium levels or high calcium levels. Okay, these 2 points you need to remember. So how does this patient present? There is decreased levels of antidiuretic hormone. So this hormone job is to reduce the diuresis. If this hormone is not there, there will be diuresis. So you will urinate a lot of urine. Urinate a lot and lot and lot. If he's urinating a lot and lot and lot, the plasma will get concentrated and the osmolarity will increase. Urine he is passing a lot, it is not concentrated at all because there is no antidiuretic hormone. So urine osmolarity will come down. Serum sodium levels will go high because of concentration of intravascular volume. Always get potassium and calcium levels done because low potassium and low calcium levels can cause nephrogenic diabetes insipidus. CT scan if you're thinking of central or cranial cause of diabetes insipidus. If you're thinking cranial cause, then also get pituitary function. There might be other hormones which are also deficient. There is a test known as water deprivation test to diagnose and diabetes insipidus, where you don't give the patient water, still the patient is urinating a lot. So there is no antidiuretic hormone effect happening on the kidney. So you know this is a diabetes insipidus. How to differentiate if it is a cranial diabetes insipidus or it is a nephrogenic diabetes insipidus? So you give an antidiuretic hormone to this patient. If it's a cranial, there will be concentration of the urine. If it's a nephrogenic, if you give this antidiuretic hormone also, the kidneys are resistant to antidiuretic hormone in nephrogenic diabetes insipidus. Still the patient will continue to urinate a lot and the urine osmolarity will be very low and the plasma osmolarity will remain very high in spite of giving ADH hormone externally. That is known as ADH stimulation test. How do we treat this patient? Nephrogenic diabetes insipidus, you just need to treat the underlying cause. You can't do anything. If it's a cranial one, desmopressin intranasally, you can give 1 mic. What about dehydration? Because this patient is passing urine like crazy. So what you do is you give enough fluid so that it matches the output. So better is to catheterize this patient, monitor the urine output closely. Whatever the urine output, that much input should be there. Okay, so input and output should be equal here. So there shouldn't be any dehydration. Input and output should be equal until you treat the underlying cause. For example, there is an hypokalemia, so you're giving a potassium pyroxenate sometime. Till then, make sure input and output is equal so that this patient doesn't go in severe dehydration. As I told you, exactly opposite of diabetes insipidus is syndrome of inappropriate antidiuretic hormone secretion. This is important. There are various causes. It might be because of malignancy, any insult to central nervous system, or any insult to your lungs. Some metabolic disorders like porphyria can cause. As there is lot and lot of antidiuretic hormone which is secreted, there is retention of fluid. Because of retention of the fluid by the kidney, there will be hyponatremia. Hyponatremia here is mainly dilutional hyponatremia, what is causing. But this is more theoretically what I'm talking about, dilutional hyponatremia. But exactly we don't know what happens in syndrome of inappropriate ADH secretion, because these patients will remain euvolemic. If you're seen in hyponatremic causes, what I discussed, syndrome of inappropriate ADH secretion comes in euvolemic causes of hyponatremia. Why they remain euvolemic, still a mystery, we exactly don't know. How do we diagnose and syndrome of inappropriate or SIADH? Urine sodium levels should be more than 20 millimoles per liter and urine osmolarity should be more than 500. That's when we really label them as syndrome of inappropriate antidiuretic hormone. But usually they will not ask you this. It's understood there will be underlying insult will be there, and it will be understood that this patient is having hyponatremia because of an SIADH. How do we treat these patients? Depends on the symptoms they are presenting with. If this patient is asymptomatic, just fluid restriction. Mild to moderate symptom, also fluid restriction. Severe symptoms, that is seizures, coma, altered sensorium, there is nothing but reduced GCS levels, then hypotonic saline needs to be given. These symptoms are mainly because of low sodium levels. So you need to correct the sodium. As we learned in our nephrology chapter that whenever the patient presents with seizures or reduced GCS, always treat them with hypotonic, that is 3% saline. Don't remember this. It is never used. You need to involve the renal consultant. That is, you need to involve the nephrologist to treat an SIADH. From emergency point of view, we are just seeing whether the patient is asymptomatic or having severe symptoms. Mild to moderate also, we don't treat it. Severe symptoms means seizures or reduced level of consciousness. If present, hypotonic saline. Plus or minus vasopressin, if required, you can give it. Any questions still here? You can ask me before we go into ovarian hyperstimulation syndrome.
Sir,
Hello, sir.
ADH stimulation test and diabetes insipidus, sir.
What happens in, as I told you, there are two kinds of diabetes insipidus. One is cranial, another one is nephrogenic. Okay, nephro, I'll just write it here. What happens? What is the pathophysiology? Here, ADH levels are normal, but when they are acting on the kidneys are resistant to ADH. They're just not acting on the kidneys. In cranial cause, ADH levels are low. So what do we do when we give ADH? Okay, when we give ADH, if it is a cranial cause, the urine will get concentrated. Okay, the frequency of urination will come down, or the urine output will come down. If you give ADH in a nephrogenic diabetes insipidus, what will happen? It is resistant. If you give more exogenously, if you give ADH, although still the symptoms will remain then. Urine will not get concentrated, urine output will be high. So you know this is a nephrogenic if the symptoms still persist. So it's clear now?
Yeah, sir.
Sir, in the treatment of the nephrogenic diabetes insipidus, which fluid is best for treatment? Rehydration.
Rehydration, crystalloid fluids will be using either normal saline or Hartmann's.
Okay, thank you.
Assalamu alaikum.
Walaikum salam.
Just ask about in SIADA, vasopressin just given for severe cases with no case of chronic SIADA, or
We
just
can plus or minus is usually on the advice of nephrologists. We give it vasopressins. You can give it or you can hold it. But for us, acutely important thing is to remember is hypotonic saline will be required in this patient.
okay.
Dr. Amin, I have a question. In thyroid storm management,
Okay.
there is a role for the benzodiazepine sedating the patient.
Yes, you can give benzodiazepines in these patients. Okay, for example, if this patient has altered sensorium and he is very agitated, you're not able to control him. So how we treat it at this point of time, we call it as an acute disturbance in the behavior. Acute behavioral disturbance, we call it. The name is ABD, acute behavioral disturbance. Because when they are agitated and aggressive, you'll not be able to take any history. We don't know what is happening. One of the causes for acute behavioral disturbance is thyroid storm, and the treatment for acute behavioral disturbance is giving sedatives like benzodiazepines. You can use it. Again, we'll discuss about this in more detail in psychiatric chapter. If they are agitated, aggressive, they're not allowing you to treat, yes, you can give benzodiazepines.
Okay, thank you.
Sir, how vasopressin is acting here, sir, in the SIADH?
In SIADH, they block the receptors. Where the ADH receptors are there, they go and act as an antagonist and they will be helpful. Again, we usually don't start them in the emergency department. It's a hypotonic saline what we are worried, because symptoms are mainly because of hyponatremia, not because of increased ADH hormone secretion. That's the reason I've written plus or minus here. Usually started by nephrologist, not an emergency drug.
Excuse me, sir.
Yes, please.
In myxedema coma, the patient have a hyperthermia. Am I right?
Hypo, low. Hyper is seen
Sorry,
in thyroid
yes,
storm and all.
hypothermia.
Yes.
They advise that to do active rewarming or passive rewarming. Better to do passive rewarming, not active.
It depends on the treatment. It depends on the how low is the temperature. Usually it will not be very drastically low because there will be an insult. If they are presenting with a myxedema coma, it will not be hypothermia. Usually these patients will be in sepsis. Okay, because of sepsis, there is predisposition to myxedema coma. In sepsis, we know there should be a high temperature because there is a severe infection. This patient will have the temperature in the normal range or slightly high or slightly low, like low in the sense like 36 or 35.4, like that. Once you start the treatment, usually the temperatures will go high. So nothing needs to be done in per se for the temperature. Passive rewarming, like giving a blanket or beer hug, should be sufficient.
Okay, thank you.
Dr. Amin, in myxedema coma, patient will present with bradycardia. Will follow bradycardia management ولا will give treatment first priority for hypothyroidism?
Unlikely they present with bradycardia. Again, you need to follow the bradycardia algorithm. Unless they are in any drug overdose, then you'll be giving the antidote as the first one. Okay, otherwise you just follow blindly the bradycardia algorithm. If they are life-threatening features along with the bradycardia, you need to follow the bradycardia algorithm.
Okay.
Dr. Amin?
Yes, please.
Yes, one of the points you made there was not giving patient aspirin. Patient with hyperthyroidism. So I was asking, in myocardial infarction induced hyperthyroidism, we know that aspirin is known to reduce both the morbidity and mortality, and it's one of the first agents to be given. So in that state, what do we do? Because we needed to give aspirin at that point when the patient was having myocardial infarction, but at the same time the patient is having a thyroid storm. So, and then which aspirin is
I understood your question. So basically, an acute myocardial infarction this patient is having, which just triggers the thyroid hormone. So you want to give an aspirin according to the odd guidelines because it reduces morbidity and mortality. That at that point of time, you need to see how severe is the thyroid storm symptoms this patient has presented with. If there is severe, then you need to see benefits, risk with the benefits. If benefits are more than the risk, for example, the symptoms are mild, then you can go ahead and give aspirin 300 mg loading dose. If the benefits are not as compared to the risk, this patient is having a severe thyroid storm and he is hemodynamically compromised, then you will hold on till the thyroid storm passes away. Usually, once you start giving propranolol, the symptoms will come under control. Then you can give the aspirin. In acutely, we are avoiding it. Once the acute episode is gone, you can give the aspirin.
Okay.
Now let's study about ovarian hyperstimulation syndrome. This is been tested a lot recently. Why? Because of IVF, that is intrauterine fertilization. Infertility is very high nowadays because of various factors. Infertility has gone high. Couples are going to IVF, that is in vitro fertilization. What do they do in vitro fertilization? They stimulate the ovaries so that they can get ovum, that is eggs, as many as possible. Then they do in vitro fertilize. They'll fertilize with an sperm and get the embryos out of it. So that is basically what they do in IVF. So ovarian sometimes when they stimulate the ovaries, it is not totally in their control how much to stimulate. Sometimes it happens or it results in overstimulation. Whenever there is an overstimulation of ovaries, there are vasoactive factors which get secreted. There are various vasoactive factors. Basically, it causes vasodilation. Vasodilation will cause increased capillary leaking. Increased capillary leaking will cause leaking of the fluids into the interstitial phase, resulting in edema. So it can cause ascites, hydrothorax, that is accumulation of the fluids, that is pleural effusion can happen here. Sometimes it can be so much of ascites resulting in a compartment syndrome also. Because this fluid, there is a third spacing, loss of fluid into the tissues, there is reduction in intravascular volume, hypovolemia occurs. So decreased perfusion for the vital organ, especially for liver and kidney, resulting in failure. Decreased intravascular volume will result in hypercoagulability. So there is a very concentrated, that means hematocrit levels are really high, HCT levels are high, very concentrated blood is going on. Through thromboembolism can happen. This is quite similar to what we learned in HHS. Same mechanism, thromboembolism can happen here also. So what are the symptoms they present with? We know there is a lot of accumulation of fluid in the tissues, so and ascites will happen. So the main symptom they'll present with abdominal discomfort due to ascites, tissue edema. Once this ascites is quite significant, it can cause compression on the diaphragm, resulting in breathing difficulty. It hampers the GI motility that results in nausea, vomiting, and diarrhea because of increased compression on the GI tract. Kidney injury can result in acute kidney injury, resulting in oliguria. Peripheral edema also can happen because of acute kidney injury. Lethargy and rapid weight gain. These are the classical symptoms what they present with. But how to pick it up from the examination? Usually they'll say this patient has undergone IVF. There's something which says that there is an ovarian hyperstimulation is happening. Mainly they'll give this patient has undergone an IVF or has taken drugs which will cause ovarian hyperstimulation. So it will be easy to pick up the diagnosis. Investigation is where they will be testing you on. They will be asking you what are the changes seen in investigations. As I told you, there will be reduction in intravascular volume resulting in concentration of hemoglobin. So there will be increased level of hematocrit. So one of the finding is increased level of HCT. Hypercoagulability state will be there. WBC counts will be high. These WBC counts are not because of the infection, it's because of the pathophysiology, what is happening. Okay, so they basically it's suggest that more the WBC count, the more serious or the more severe is ovarian hyperstimulation which is happening. It's not because of the infection. Don't start on any antibiotics. It's always a good idea to get a liver function test and renal function test, because both of this can go liver failure and renal failure can be seen in ovarian hyperstimulation. That's why it is important to get LFT and kidney function test done. What is the treatment? Though I have written so much, it's just a symptomatic treatment what you can do. There is no specific drug available for this. For example, if there is a significant ascites, do an ascitic tap so that he feels better, the abdominal pain comes down, the breathing becomes difficult. Because of increased in ovarian size, because of ovarian stimulation, complications like ovarian torsion and ovarian hemorrhage can happen. Large cysts can appear in the ovaries because of hyperstimulation. The ovary size has enlarged, so it can rotate and cause ovarian torsion. So involve the gynecologist and do a surgical intervention. Okay, so basically it is symptomatic treatment what you're doing. This is an important topic. Don't ignore it, because increasing cases have been encountered in the emergency department where people are clueless about what to do about ovarian hyperstimulation. That's why they're testing in the exam. So be sure or don't forget to read about it. Any questions you can ask me before we go into recall questions?
Assalamu alaikum.
Walaikum salam.
How in treatment of SIADA we will give vasopressin?
Sorry, can you please? In SIDH, we don't start vasopressin from as an emergency patient. We are just more concerned about low sodium levels. So hypotonic saline, what we'll be giving. Okay, it's more of a nephrologist who starts these drugs. It's an antagonist to an ADH receptor. So we are not bothered about the drug because it's a chronic treatment. We are more worried about the acute treatment, acute symptoms, what they are presented with. Acute symptoms will be because of low sodium levels. So we'll correct the sodium levels.
Okay.
Doctor, for the ovarian stimulation, this one, the last one, you can repeat what is the management in the ER?
ER management, only symptomatic management. As if there is a gross ascites causing symptoms, you can do an ascitic tap. So those kinds of, if they are presented with an ovarian torsion or an ovarian hemorrhage, then you might have to involve the gynecologist. So nothing particular treatment is this, mainly symptomatic treatment.
Okay.
So let's go with the recall questions. We have a 22 years old young individual who has come in with insulin dependent diabetes mellitus, present to the emergency department with polyuria, polytrypsia, and weight loss. His ketones are 3+. Okay, and blood glucose is 35.6. Intravenous excess has been obtained and blood has been taken. Results of venous ABG and urea electrolytes shown below. As you see here, they have just asked you to calculate the anionic gap. Okay, anionic gap we calculate as sodium plus potassium, and we are subtracting through this is chloride plus bicarb. We need to add it.
38.
Sometimes they may not give you potassium values, then you can ignore it. As they are given potassium value, you need to include it here. If you calculate it, it will come as 38.2. Okay, will not, it's 135 plus 4.2, then minus, you need to do the chloride, which is 95. Yeah, then you need to do the bicarb, what they have given here, that is 6.
Bicarb 6.
Okay, 101 with what value comes? It comes as 38.2. We have a 30 years old female came to the emergency department with complaints of palpitations, restlessness, diarrhea. On examination, her pulse is 140, blood pressure is 140/60. ECG shows only sinus tachycardia. What's the initial step in the management? Diagnosis? Thyroid storm is the diagnosis. Preferred beta blocker is propranolol. Though bicaprolol also can be given, but preferred one is propranolol is the drug of choice. The first step is propranolol always. An alcoholic was found collapsed on the roadside and brought to the ED by the police. His blood tests are suggestive of an AKI. VBG shows metabolic acidosis. BM is 6.1. What type of fluid is suitable for this patient?
Normal saline.
As BM is normal, you can just give first thiamine. Please mute. As BM is normal, we can give thiamine plus normal saline. Okay. If this patient, that is the glucose levels are quite significantly low, for example, 6.1, then you can give thiamine plus dextrose together. Okay. That has been recently put up in RCM learning. They have an SBA question in that explanation. If you go, they're stressing that there is no evidence showing that dextrose will predispose this patient, alcoholic patients, to 1x encephalopathy. The evidence are almost negligible. Okay, that's why they say you can go dextrose plus thiamine if the blood glucose levels are at the lower side. If they're lower, give both together, no harm. If they are in the normal range, then give thiamine first, followed by glucose.
But why, Dr. Normal saline? Dextrose because the alcohol have some problem in the liver, right? Sometimes some chronic liver disease or something. That's why we give dextrose. We avoid normal saline in alcoholic. صح?
We give dextrose because any patient who is an alcoholic might have a liver injury. Okay, liver injury are prone to cause hypoglycemia. Yes. But if this patient is in hypoglycemia, to give saline now, dextrose, no. His BM is fine here.
Normal.
That's why we give a normal saline. Always remember that dextrose, you will not use it as a normal fluid to resuscitate. Normal saline or Hartmann's or plasmolite M, those are the fluids what are preferred. Crystalloids are the fluids what are preferred. Okay, don't give colloids. Colloids are never used for resuscitation. Colloids only given if indicated. For example, hypoglycemia, then you're giving dextrose. For example, you're doing an ascitic tap, then you give albumin, you can give albumin at that point of time.
Now this doctor, BM abbreviation for body mass index, صح?
Also he
طيب, that means it's not glucose.
Each one at a time, because it's one at a time, please.
I mean, it is mentioned body mass index, not mentioned dextrose. Yeah, it's not mentioned glucose is high. He give
Not
me
body mass
only
index.
body mass index.
It's
Okay.
not
No,
body mass
no,
index.
no,
Not
no.
body.
The capillary blood
glucose level.
glucose in British medical, abbreviated
Sorry?
like this.
Where is body mass index is mentioned? It's not mentioned here.
BMS, this one. BMS, what is abbreviation for what?
Blood glucose.
Blood.
Blood
This
glucose.
is
That's
blood glucose
BMI.
levels.
Okay,
Abbreviation
okay,
BM.
okay.
Okay, BM is a commonly used abbreviation. You need to remember. They will use abbreviations in the exam. Okay, it's not BMI what they're suggesting. BM of 6.1 is very low. Okay, can't be and BM. Usually along with it, they will mention this one also, millimoles per liter. It will be 6.1 millimoles per liter, BM. So this is nothing but random blood sugar levels.
Okay, okay. Tamam.
Patient is on carbimazole for his thyroid condition. Now he complains of a sore throat and an oral rash. Investigation of choice they're asking.
Full blood count.
Count. Full blood count.
CBC. CBC.
What?
Because one of the
This.
side effects of carbamazepine,
It causes
Agranulocytosis.
agranulocytosis. Yes.
agranulocytosis. It causes classical or pathognomic symptom, presenting symptom known as necrotizing stomatitis. I'll show you the picture in next coming up question. There will be one picture that is known to see whether this patient is having agranulocytosis, a side effect of carbamazole, which predisposes to necrotizing stomatitis. Full blood count will be the preferred diagnosis. Okay, this is the reason behind it. How the lesion appears, I'll be showing in coming up slides. We have a 4-year-old boy was brought to the emergency department by his mother, complaints of fatigue after ingestion of his father's tablet. She has got the bottle of the tablets, and tablets are bisoprolol. On examination, his pulse is 50 per minute and the blood pressure is 90/60. ECG shows a first degree of heart block. What is the best treatment in this patient?
Glucagon.
No, atropine.
Why
When
atropine?
you are having an overdose,
We will treat atropine, then glucagon.
Overdose.
whenever there is an overdose, use the antidote first. Antidote is always first. Okay, whenever there is an overdose, antidote is first in adults as well as in pediatric age group. Once you are given antidote, till this patient is in bradycardia, you can give atropine. Atropine usually doesn't act well because atropine acts on the vagal tone. Vagal tone will not be increased here, which is causing bradycardia. If the pathophysiology behind the bradycardia is increased vagal tone, atropine acts well. Otherwise, atropine usually doesn't act well.
Sir, in the Google it's incorrect answer. Atropine.
Oh, okay, we'll correct it. I think by mistake I have done it. I will correct it. The right answer will be glucagon here. Okay. What if I given in the Google form as atropine? It is a wrong answer. The right one is glucagon.
Yes, sir. I choose the glucagon. It's showing atropine.
Yeah, we'll correct it. Young female with ovarian hyperstimulation syndrome. What abnormality is not found in the patient? What's not seen? They are asking.
GT less than
High protein.
High temperature
less
count,
than-
yes. Hypercoagulability, yes. Hypoproteinemia, yes.
Yes.
Hematocrit values are seen high, not low. They are seen high.
Yes.
Because the right answer will be hematocrit levels. This is necrotizing stomatitis. What I was telling previously, this is necrotizing stomatitis. Okay, again, we are getting an complete blood count. In UK, it is known as full blood count. Don't get confused. Full blood count and complete blood count both are same. This is necrotizing stomatitis caused due to agranulocytosis, common side effect of carbamazole. Multiple times they're asking the same question. We have a 30-year-old female who is a known hypothyroid, came to the ED department with confused lethargy. On examination, she has a low-grade fever, tachycardia. On BBG, the following things are seen. What is the urgent test to be considered in this patient? What is the diagnosis?
Maxedema.
No, not thyroidostom. It's a maxedema coma what this patient is having.
Maxedema coma, yeah.
Yes.
T4,
Get the thyroid levels in this patient. This question, most probably it appeared like this. So I have formed a question. Okay, then we'll discuss more about the previous one. The same thing, I have formed a question here. So we have a 78-year-old gentleman who is a known case of CA lung brought to the emergency department with complaints of altered sensorium since last 2 days. On examination, heart rate, blood pressure, saturation, and respiratory rate are within normal limits. Lab shows there is an hyponatremia. Potassium is in the normal range. What is happening here? What is the diagnosis?
SIDH saline.
SIADA syndrome.
Fetal
Fluid
hyperkalemia.
restriction.
This patient is having
Yes.
yes. This patient is having severe symptoms because of low sodium levels in SIADH patient.
3% saline.
3% saline needs to be. If the same question, if I change it instead of altered sensorium, if I just change it as a generalized weakness, what will be the answer?
Fluid restriction.
Fluid restriction.
Fluid restriction will be the right answer. Good. So the history what we had got is hyponatremia in a scenario where the patient had lung cancer. What was the treatment asked? So most likely it was like this. So I have framed the question. Okay, it is not there in the blueprint what we are given, but you can note it. It's the same thing. We have put it in a question form now so that it becomes easier to discuss. We have a 26 years old male presented with palpitation and shivering on examination.
Sorry, sir.
Fluid restriction, the answer?
Yeah, the answer is fluid restriction in the Google form, the question.
If
The
this
other question,
if I change this one, we don't know symptoms what they are given. So if hypotonic saline, we'll give it if the patient has presented with seizures or low GCS or altered sensorium, same thing. Fluid restriction, if the symptoms are mild or asymptomatic, fluid restriction.
Okay, thank you.
Okay, because there is not much to answer here. That's why we have put it up in a question manner here so that it becomes easier to discuss. We have a 26 years old gentleman who is presented with palpitation and shivering. Heart rate is 130 per minute and blood pressure is 90/60. Respiratory rate is 29. Saturations are normal on room air. ECG shows sinus tachycardia. TSH levels are 130. What is the best treatment?
Propranolol first.
Propranolol. Again, this is a thyroid storm as a diagnosis here. We have a 34 years old female who is a known asthmatic presented with ED with complaints of fever.
One question. In a thyroid storm will be hypotensive.
Sorry?
Previous question. BB will be hypotensive.
Most of the time they present with hypertension. Sometimes they can be on the lower side, but it is a rare finding. Most of the time tachycardia with hypertension what they present, and with high respiratory rate, everything will be on the higher side. But keeping the TSH in mind and blood pressure, we can ignore it, and the options what they are given, we need to think about propranolol.
Sir, in this question, sir, it's look like adrenal crisis. So, in adrenal crisis, the patient is present with low BP.
There is not much history given to suspect an adrenal crisis. Okay, we don't know the underlying cause here to really think about adrenal crisis as a diagnosis here. Okay, more often palpitation, shivering with the TSH levels of so much, we'll always think about hyperthyroidism in this one. Okay, thyroid storm we are thinking about because TSH is very much on the higher side. Okay, don't depend only on the TSH to diagnose as an hypothyroid or hyperthyroid. Depend on the symptoms also, because TSH can be high in both the conditions. Okay, for example, in an hypothyroidism, TSH usually will be on the higher side, but in hyperthyroidism, it depends whether it's in primary hyperthyroidism or in secondary hyperthyroidism or in tertiary hyperthyroidism. Depending on that, the TSH values differ. So we only concentrate on the symptoms. We don't concentrate much on the TSH values. It will just indicate that this is something related to the thyroid and come to a conclusion depending on the symptoms what they are having. Solely don't depend on the TSH to diagnose hypo or hyperthyroidism.
So in this patient, sir, BP is low. Sir. If we give propranolol, so what do you think we are deteriorating patient?
Usually, if you give propranolol, if your diagnosis is right, unlikely the blood pressure will fall down. It might be a false reading, or the recall what was done might be on the wrong side, because all these drugs are more related to more related and more goes in favor of thyroid storm.
Okay, so thank you.
Dr. Amin, about the question, the question, you told us that if there is seizure, then we go and give the patient the hypertonic saline. If there is no seizure, we are not going to give. We don't care about
Seizures
the
are
level
altered
of
sensory.
sodium.
Sorry?
The level of sodium. We don't put into consideration the level of sodium.
Level of sodium doesn't
If it is-
matter. There is no mild, moderate, severe hyponatremia. As we studied in our nephrology chapter, sodium levels doesn't matter for the treatment. Only the symptoms what matters for the treatment of sodium.
Sir, as I know, sir, you said that if the patient is sodium is less than 115, we have to admit the patient and we have to treat the
Underlying cause, what is causing the hyponatremia, requires admission. Okay, but that doesn't mean you're starting on 3% saline for them. 3% saline in emergency department, you're only starting if they are having seizures or altered sensorium. We have a 30-year-old female who is a known asthmatic, has presented a ED with a low-grade fever since last 2-3 days, generalized weakness and reduced appetite. Heart rate is 108, blood pressure is 90/60, and respiratory rate is 24 minutes. Saturation is normal. Our regular medications includes inhaler and prednisone 10 mg once daily. Lab investigation shows sodium slightly on the lower side, potassium slightly on the higher side. BM is slightly on the lower side. Fluid is ongoing. IV antibiotics given. Next step.
Option A,
Hydrocortisone 100.
Option A, start.
Hydrocortisone 100 mg IV stat, you can give it, or you can give 50 mg IV stat followed by every 6 hourly 50 mg, or hydrocortisone 100 mg followed by infusion 200 mg over 24 hours you can give. So any of the treatment protocols, so they're basically asking you what's the treatment for adrenal crisis. Adrenal crisis, we are thinking more about because sodium is on the lower side, potassium is on the higher side. Sugars are also going on the lower side slightly. So keeping this picture and keeping the prednisone daily intake, we are thinking about adrenal crisis, and we are giving hydrocort 100 mg IV.
Sir, in this case, the BP will become all right with this, or should we do something?
BP usually
for
will
the
pick
blood
up
pressure?
with this. Hydrocortisone itself, BP will pick up. If BP doesn't pick up with hydrocortisone, then you can start giving IV fluids.
Okay, sir, thank you.
We have a 46-year-old female presented to the ED with complaints of upper abdominal pain associated with the recurrent episodes of vomiting and fever. She's a known case of diabetes on insulin, has stopped taking insulin because of recurrent vomiting. Heart rate is slightly on the higher side, BP is 90/60, saturation is 96 on her room air, PM is 11.2, pH is 7.21, bicarb is 12. Blood test which will help you in diagnosis. I'll help you in diagnosis.
Blood ketones. Yeah.
Blood ketones. Always remember, blood ketones are better than urine ketones. Okay, blood ketones are always better than urine ketones. If both the options were given, I'm telling, still select blood ketones because ketones levels are required to make a diagnosis of DKA. Okay, we have acidosis here, makes a diagnosis. Known case of diabetes itself, another we have point here. The third point, what we need to look out is look out for the ketone levels. If ketone levels are more than 3 millimoles on blood ketones, then we need to treat it as a DKA.
Sir, blood ketone will take time. What do you think if we go with
It's a bedside
urine
investigation.
Okay, sir. Okay.
It comes like a glucometer. It's a strip. What is there? You prick it and you check it. So
in
it
India,
gives.
they are going with urine dipstick, sir.
In urine dipstick, the problem with the urine dipstick is if he is not able to pass urine, then you need to wait. If you're planning to catheterize and get the urine, again, it takes time. So blood ketones is always preferred and it's more sensitive compared to the urine ketones.
Thank you.
A middle-aged male brought to the emergency department with complaints of recurrent vomiting, abdominal pain on examination, blood pressure is on the lower side, slight tachycardia, BM is very low, potassium is high, likely management. Or what's the diagnosis?
Adrenal crisis.
Again, it is an adrenal crisis what this patient is having. Why adrenal crisis this patient is having? This patient is having low blood pressure. Okay.
Potassium high, blood pressure low.
And low glucose also, low BM. Keeping all this in mind, we need to always think about especially high potassium and low BM and low sodium. If you're seeing low sodium are also present, you need to always think of adrenal crisis. Give hydrocortisone.
Yes. Sometimes there is eosinophilia also.
Yeah, but we're looking for more obvious symptoms here. We have an young male who has presented the ED with complaints of lethargy, polyuria, and constipation. On further questioning, he says he has bone pain. You're suspecting primary hyperthyroidism. Which one of the following features are suggestive of primary hyperthyroidism? This is from nephrology. It has come up here. Elevated calcium levels. Primary parathyroid hormone secretion, primary hyperparathyroidism will cause high calcium levels and low phosphate levels. CKD will cause low calcium levels and high phosphate levels. Okay. Low vitamin D levels will cause low calcium and low phosphate level. This chart we have discussed in our nephrology chapter. What we have discussed, don't forget, this is from that. It should have been there. Unfortunately, it's here. But anyways, it's an elevated calcium what you're suspecting in primary hyperthyroidism, hyperparathyroidism. We have a 24 years old female comes to the emergency department with complaints of weight loss, even though her appetite has increased. On further questioning, she says she has increased sweating. Likely diagnosis.
Hyperthyroidism.
It's a very simple hyperthyroid diagnosis. Shouldn't be a problem. In last date, it appeared and everyone got it right. There was no issues here. We have an 8 years old child who was brought to the ED feeling unwell. pH is 7.1, bicarb is so much, and BM is 26. Likely diagnosis they are asking.
DKA.
We are still thinking of DKA here because sugar levels are very high. pH is so much. Ketones are required because we are seeing just ketones and acidosis are the two things what are required for a diagnosis in pediatric age group. But with the pH and BM, we need to always think about DKA in this kind of patients. HHS, unlikely in this, it will be more than 30 millimoles per liter, and 99% of the time it's seen in the adults. Sepsis, it can be a sepsis, but with the investigations what they are given, it more looks like an DKA. We have in 55 years old a known case of a diabetes present to the emergency department. A diagnosis of HSS was made. Next best step.
IV fluid.
IV fluid 1 liter.
IV fluids. Okay. IV fluids is the mainstay of HHS treatment. Don't start insulin. You start insulin if required. There are two indications when to start insulin. One is if beta hydroxy, there is a ketone. If I'm not wrong, beta hydroxy something as ketone comes up, which is more than 1 millimole should be there. Or if the glucose levels are not falling down more than 5 millimoles per liter, then we need to, over an hour time per liter per hour, then we need to start this. Otherwise, we will not start the insulin infusion. Only fluids are enough. We have seen patients with only fluids with glucose levels of 30 or 40 have come down to normal range only by giving fluids. Patients present to the ED with giddiness on standing up. Routine investigation shows BM of 4, sodium of 128, potassium of 5.9. Next best step in this patient. So what are you thinking here? Adrenal crisis. Giddiness standing up is postural hypotension. These are please mute. These are one of the initial findings what we'll be seeing on. Okay, again, adrenal crisis. You know, adrenal crisis is so much important because of multiple questions which have appeared. Patient is a known case of diabetes on oral anti-diabetic medications. These are the oral and on insulin, also present with the vomiting and abdominal pain. VBG shows metabolic acidosis with high lactase. Patient is immunologically stable. BM is 6.7. What is the likely diagnosis?
Euglycemic DKA.
Euglycemic DKA.
It is an euglycemic decay, especially if you're seeing an SGLT2 inhibitors along with diabetes. If they are present and there is some acidosis, always think about euglycemic decay. Okay. Nowadays, euglycemic decay is becoming more and more. That's why they have asked the question. Patients are aware because their sugar levels, they'll check at home, the sugar levels are all high and they give themselves subcutaneous insulin, but still the symptoms are persistent. They come to the emergency department. That's the main thing what happens in euglycemic decay. We have in 3 weeks old boy, previously well in is brought to the emergency department, 5 days history of diarrhea and vomiting, last vomited at 24 hours ago. On triage, he appears alert and interactive and appropriate, slightly looks miserable. He is mildly tachycardic with the dry lips, but observations including blood pressure are within normal limits. He is found to have blood sugar levels of 2.1. Ketones are 1.3 millimoles per liter. He has no other significant past medical history. Other household members had recently been unwell with similar symptoms. A blood test shows no acidosis. What is the most appropriate management?
Option B.
Give 5 grams.
Give 5 dextrose.
Orally.
Dextrogen.
Alert the patient. Hypoglycemia.
Patient conscious less than 1 year.
Patience is normal, so just give oral and recheck the glucose levels after 10 minutes. Okay.
glucagon.
هنا هيدو milk صح؟
Milk should have been the ideal one because this is almost a neonate, less than 4 weeks. Ideally, less than 1 year old, we give milk, breast milk or milk products, supplementary breast. If that is not given in the option, you can still go ahead with the dextrose gel orally. You can give it.
What is sir Amitabh?
Amitabh is an anesthetic, local anesthetic, which is usually applied so that usually used in pediatric age group. It is applied locally, that is over the skin before you insert an IV cannula. It becomes pain-free local anesthetic. Commonly used in NHS, so in pediatric age group, so that the prick is pain-free while inserting an IV cannula. Any questions you can ask me? This was the last. Sorry for the inconvenience which has caused initially because of technical difficulties. Sorry, apologies for that.
Sir, I have a question regarding the adrenal insufficiency.
Okay.
There are many types adrenal insufficiency, like primary and secondary and tertiary. Can you explain that a bit?
We are not going into primary adrenal insufficiency mainly because we are not worried about. They don't present to the emergency department adrenal insufficiency. It's the adrenal crisis what they present to the emergency department. That's the reason we have skipped those things and we have just concentrated on adrenal crisis. We didn't talk about Cushing's syndrome also because of those are the chronic symptoms. They'll not test you in the exam or they'll not present to the emergency department. You don't diagnose a Cushing's syndrome in emergency department.
Okay, so thank you.
Sir, there's no question. I need to be given.
One of your time, please. Please go ahead.
Okay, so I said I used to love your tables of summary for because it helps me to remember a lot of things. This confusion between adrenal crisis, Cushing's disease, and the Cone syndrome, and then nephrogenic diabetes insipidus. So I thought maybe you put it on a table so that one can easily scan through, so that you know the various specific differences.
We'll try and see to put up if it's possible, okay? Because everything can't be put up in a tabular form. We'll try if it's possible. Because same things, if they come up, we can put up in tabular form. We'll go through it and we'll see if it's possible. We'll definitely share it in the group.
Okay, thank you very much.
Someone else had the question, you can ask me.
Yes, sir. Desmopressin ideally to be given intranasally. If any trauma or any contraindication, we can give orally or IV.
I'm not sure because till now I didn't face that difficulty.
Okay, sir. And why, sir, one question more. In hydrocortisone in adrenal crisis, we are selecting hydrocortisone everywhere. So why not the DEXA or methylprednisolone?
It is shown that it has more effect because you need to address more of a mineralocorticoid, and at the same time you need to cortisol and mineralocorticoids both needs to be addressed. Both will be addressed very well with the hydrocortisone. Prednisone also has one-on-one effect, but hydrocortisone is preferred. It acts much better at the adrenal levels.
Thank you.
There is an alcoholism patient, next hypoglycemia and hypertension patient, next first step, whether we have to give thiamine or IV fluid.
So you are telling me if it's a patient, an alcoholic patient you are talking about, was come in with BM of, for example, 2.1, and what fluids we will give. We can give both thiamine plus dextrose at the same time, if this is the ideal option. Second ideal option to select will be only dextrose also you can give it. Don't worry about the warnings and encephalopathy, not proven, or there's not enough data to support it.
If it is blood pressure in normal, sir, then thiamine plus normal saline.
If BM is normal, then you can give thiamine plus normal saline. Dextrose is not required, right? Why you want to give him dextrose at that time?
But if it is best of next best step, what you will give if they give the thiamine, one answer, one is normal saline, what will select if they ask another question?
So,
normal saline.
for example, if this is a patient alcoholic, you're not trying to resuscitate, blood pressure is normal, then you can give thiamine as the first drug, okay? Because you don't need IV fluids also in this patient. Why you want to resuscitate? For example, the same patient, the BP is on the lower side, then give NS first or Hartmann's first. Do fluid resuscitation first because the blood pressure is on the lower side. In alcoholics, we need to always suspect because of dehydration, so we need to give normal saline or Hartmann's. Hartmann's is usually avoided in alcoholics because there might be underlying liver disease, so Hartmann's is not preferred in liver disease disorder. So normal saline is the preferred one.
Okay, sir. Thank you. Thank you.
Anyone else has any questions? Okay, we'll stop here. Thank you, everyone.
Thank you.